Chronic kidney disease. Kidney functions are remove waste, to balance fluids and minerals, to control blood pressure, keep bone healthy, regulate hormones, PTH, and to help to make the red blood cell by EPO. Kidney. Every day it filters 200 liters of blood. When blood enters into the kidney, bad materials go outside of body through urine, and pure blood comes back to our body. So when there's renal impairment, kidney's important role will not work, which will lead to bad consequence. It will lead to muscle cramp, edema, pruritus, fatigue might not happen. Kidney diseases include heart disease, heart attack, high blood pressure, stroke, anemia, where there is not enough red blood cells, weak bone, kidney failure, secondary hyperparathyroidism, uremia, and vascular calcification. Chronic kidney disease occurs in 10% of the population, and the risk factors are diabetes, hypertension, other cardio disease, obesity, which is BMI over 30, smoking, older age, and eating salty food. Chronic kidney disease, the definition is the estimated GFR is under 60 milliliter that presents for 3 months or more. The common electrolyte disturbances in CKD patients include hyperkalemia, hyperphosphatemia, and hypercalcemia. Let's check out the kidney function diagnostic test. There are two simple tests, ACR test and GFR test. ACR test is in shortened form of albumin to creatine ratio. It detects protein in the urine, and it is the first sign of the kidney disease, whereas GFR test stands for glomerular filtration test, how well the kidney is filtering, is there any damage. Serum creatinine is under 60 milliliter. It is a waste product in the blood, marker that diagnoses CKD, checking the creatinine level in the blood. So under creatinine clearance of 60 milliliter implies the chronic kidney disease. Calculating creatinine clearance by Croft-Gault equation is as follows. eGFR, which is estimated glomerular filtration rate, is a marker that detects the creatinine level, which is waste product in the blood. Underweight patients calculating GFR based on blood creatinine tend to be overestimated. Let's check the weak bone disease caused by CKD. There is mineral and bone disorders, in short term MBD, because of parathyroid hormone. There are two ways of promoting absorbing calcium as point of blood. First of all, calcium increases from bone to blood. Calcium increases by reabsorbing calcium from kidney to blood in Henle loop, distal tubule, collecting tubule. But phosphamide decreases by inhibiting reabsorption. For example, calcitriol decreases parathyroid hormone but absorbs calcium in gut. Chronic kidney disease can cause mineral and bone disorders. Why? Phosphate is no longer excreted efficiently by kidney. Activation from vitamin D is that calcitriol is less calcitriol, less calcium reabsorption, and lower blood calcium level. Anemia. Anemia decreases in our red blood cell or hemoglobin level in blood. It is less oxygen is carried, so people feel tired, weak, red shirtness, and can't exercise well. Hemoglobin under 120 in female, and hemoglobin under 140 in male. ESA mimics EPO, erythropoietin. ESA is an erythropoietin stimulating agent. It is injected into the bloodstream, goes to bone marrow, and treats anemia. To make red blood cell, iron, folate, vitamin B12 is most needed. Therefore, ESA should not be given until other causes of anemias are corrected, which are these three factors. ESA stands for exogenous form of hormone EPO, erythropoietin produced in kidney. The risk factors of these are cancer patient, history of ESA, uncontrolled hypertension, cardiovascular disease, and thrombotic event. The target patients are people who has lower hemoglobin. ESA therapy can be given IV, but not as a tablet, because it is a damn huge-sized protein. We have erythropoietin and erythropoietin. They increase the hemoglobin level to treat anemia. ESA stimulate the bone marrow to make red blood cells. 6% of population hemodialysis patients use EPO, and 94% populations uses EPO. Diuretics: furosemide, ACTZ, spironolactone, and amiloride. Spironolactone and amiloride preserves kalium in blood. Furosemide is a loop diuretics that treats hypertension, heart failure, edema, kidney disease. It inhibits natrium and chloride reabsorption in ascending loop of Henle. It is very strong and works in 6 hours, so brand name is Lasix. Hydrochlorothiazide is a thiazide that inhibits natrium reabsorption in proximal part of distal tubule. It excretes kalium and it is in moderate strong. Spironolactone is kalium-sparing diuretic. It is aldosterone antagonist which inhibits natrium absorption in distal tubule. It is a weak diuretic and side effect is hyperkalemia. Amiloride is kalium-sparing diuretics. It inhibits natrium reabsorption in the distal tubule by blocking channel. It interferes with natrium and kalium exchange and reduces urinary kalium excretion. It is a weak diuretic and side effect is hyperkalemia. Let's check out the bone drug. Mineral and bone disorders. Treatment goal is to lower the serum phosphate level. We have a sevelamer. This is a phosphate binder. It lowers phosphate in hyperphosphatemia by binding in the gut. Please take 3 times a day. Take with meals. Prevents the phosphate absorption in the gut and lowers the blood PTH level. The second is to decrease the high parathyroid hormone. Calcitriol lowers PTH, but also increases intestinal absorption of kalium and phosphate. It is activated version of vitamin D, and it should be reserved for severe treatment. It is used for secondary hyperparathyroidism when, for example, it is 2 to 9 times higher than normal PTH. The third treatment goal is to lower high serum calcium. We have Cinacalcet. It reduces everything. It makes people to think, oh, there's more calcium than it really is. I don't have to produce more parathyroid hormone. It treats hypercalcemia. The side effect is hypocalcemia. Hemodialysis. 3 times a week. It is the blood taken from the patient, enters the filtrating machine, then come back to the patient. It replaces some functions of the kidney. For last stage CKD patient, diuretics don't work for the patient because patient cannot make urine. In this case, we assume the patient's eGFR is less than 10 ml per minute